so on and so on. And you see that on the right, I put what is the driving force for removing the molecular weight substances. And you see this is a convective action. So as soon as you want to increase molecular weight, size, and if you want to be more effective, you need to get convective. Maybe the next step would be additional effect with absorption, but this is still part of the discussion. Now, when we talk about convective-based therapy, this is a summary. On the left side, I put what now is called expanded hemodialysis, but just to make sure you understand, this is not really new. This is a revisited concept that you apply almost every day. As soon as you get capillary dialyzer plus ultrafiltration control, you do inside some internal filtration. Now, the trick is, of course, to increase resistance within the fibers and to increase the permeability, and then you develop a sort of concept, which is called, from my side, internal hemodiafiltration. On the right side, you get online hemodiafiltration, and you understand, based on the transmembrane pressure diagram on the bottom, which the perspective is completely different. Because on the first part, you remove a lot of water, ultrafiltration, when you drag the solute inside, and then you substitute post-filter. Most post-filters, sometimes pre-filtered, but in Europe, 80%. And you see the profile of the pressure is different. So, two different aspects relying on convective-based therapy. Now, if you go to this, the case for the HDX, which is expanded, you understand that everything is driven by the blood flow regime and the resistance. So you cannot control this transmembrane pressure. Everything is based on the flow, the resistance created by the diameters of the fiber. So at the end, you conduct a convection, which is almost just depending on the blood flow. If you go low blood flow, you will get very low convective action, meaning that this is uncontrolled convective dose that you are delivering to your patient. Of course, if you try to get higher blood flow, you can have, I will show you in a minute, some higher performances. Now, this is clearly explicited by some work from Ronco in Vicenza, where they compare, and you know that they scan the dialyzer with a sort of dyed solution to show what's happened inside the filter. And you can see on the pictures, depending on the size and the surface of the filters, Terra Nova, 400 or 500, then in this setting, you can increase or you can define what is the internal filtration reflected by this element. So based on the calculation, I put that, and to show you, depending if you are using, I would say, 1.7 square meters filters for the two sides, different porosity, you see that on the bottom I calculated the ultrafiltration that you can achieve. Okay, I don't know what's happened. Something, okay. So if you move from the left to the right, you see that you can increase from almost 10 liters per session up to about 12 or 13 liters per session. But this is completely dependent on the blood flow. If you increase the blood flow, and in the setting was 300 ml a minute, if we increase to a 400, maybe you can increase a little bit more. In this element, you can see from, I would say, 8 liters on the right panel, from 8 liters per session up to 13 liters. So it's just based on the resistance and the blood flow. Now, if you look on the convective, I would say the traditional convective hemodiafiltration, in this element, you can control almost everything. So at the end, the final set is, of course, the convective volume is completely controlled by the machinery, by the transmembrane pressure. So you know exactly what the convective dose you deliver to your patient. And this is explained on this slide. This is the transmembrane pressure, which is regulated by the machine, left part of the slide, and the ultrafiltration volume or rate on the right side. But the good point in this setting, I put that in element. If you just ramp up the transmembrane pressure slowly within 30 minutes, what you do is, of course, you put the albumin or the protein, you fool the membrane, and then you prevent albumin loss, which is very important in these parameters and setting. As I said this morning, more you put the membrane on the stress, more you expose the membrane to albumin loss. So I don't know what is wrong. Okay. In hemodiafetation, what is important, and I mentioned this dietic convective dose. This is the ultrafiltration volume or the ultrafiltration rate. Shown by this study in almost 12 years old now, there is a linear relationship between the convective dose and the removal capacity. So this is beta-2M reduction rate, and you see that if you move to 100, 120, you can remove almost 75%. So that means convective dose, this is a way to quantify the mass of the substances that you can remove during the digestion. This is easy on the machinery. You can just act and select on the auto substitution system, so the machinery will do the job for you, so it's completely automated system. Now, I put this slide already. This is showing the sieving coefficient, and we know that the permeability of the membrane versus the solute on the x-axis is defined by the sieving coefficient. But as you remember, the cut point of the membrane is a dotted red line, which is the point where the membrane is losing albumin. So as soon as you play with the sieving coefficient and you want to expand a little bit more the porosity, you expose the patient to lose albumin. So this is the point that you need to keep in mind to prevent some side effect. I showed this morning this slide showing that depending on the geometry of the membrane, the porosity, the sterilization process of the membrane, you can reduce this albumin loss. But remember, the albumin loss is almost 80% within the 61st minute of the session. So if you prevent that, you can reduce the risk of albumin loss. Also, this element, increasing the efficacy on the left side, expose the safety risk on the right side, which is increasing albumin loss. I don't want to say that all the membrane do, but you have to select the membrane which is the right one to prevent this albumin loss. Again, I don't want to go into detail, but you see that depending on the convective volume, more you put stress on the membrane and more you can expose albumin loss, depending what sort of level. Acceptable today in Europe is between 2 to 3 grams a session. No more. It's not the case in Japan. So the second aspect is to compare now the clinical performances. And this is also a very important one. As I said this morning, we start with the dialyzer and we want to perform clinical, I would say, efficiency. So depending on the solute clearances, body clearances, solute fluxes, solute mass transfer are affected by different factors or components. Treatment time, blood flow, recirculation, anticoagulation. I don't want to go into detail, but all these factors affect the performances. So at the end, what you want to achieve is clinical performances. And as you know, the clinical performances could be assessed by a different way. Clearances or percent reduction. I just selected this study from one of the first from Kirsch, showing that if you compare different, I would say, MCO membrane, A, B versus hemodiafetation, on the top you get overall clearances of beta-2M. I'm not interested by urea. In that case, we just look on the middle molecular substances. You see that we can achieve almost the same percent reduction, meaning that at the end, the membrane do as the hemodiafetation. Same for the reduction rate or the overall clearances. So you can say, just looking on this study, that in terms of performances, we can achieve, or we are very close in terms of efficacy. Now, if you move a little bit more from the beta-2M, and then from 12 kilodalton to the light chain, free light chain, lambda or kappa, you see we move to 23 kilodalton and almost 45 kilodalton. And then you can compare, the blue is hemodiafetation and the yellow is the MCO, expanded hemodialysis. You see that at the end you can achieve almost the same. So we are keeping the same efficacy over the time, but this is clinical performances on large molecular weight substances. Again, the same story for this different study, different, I would say, part. This is over the time from 30 minutes, 2 hours, 4 hours. Again, you see that performances could look almost the same. So we can confirm that internal clearances can do the job in removing some larger molecular weight substances. This is the same for these overall clearances. And on the bottom part, you see it's between 80, 90 milliliters per minute up to about 100 milliliters per minute for, I would say, the beta-2M. So very close. Now, the point is, of course, as I mentioned, we move from efficacy to safety risk. And this is the same study. If you look on the albumin loss, this is the yellow highlighted versus the blue highlighted. You see the albumin loss is moving to 4.9 as compared to 0.4 grams per session. So this is exactly what I mentioned. So you have to be careful, and you need to be aware about this albumin loss. Different study, and this is one study which has almost 8 weeks, comparing the effect of this HDX MCO on some inflammatory marker. So not clinical performances, but the way to mediate, I would say, some inflammation markers. And as you see, you can just impact the CRP, which is one aspect, but not necessarily the best. They were tackling the TNF and interleukin-6. But what is impressive already, as comparing the high flux hemodialysis to the MCO, you see the albumin trend, which tend to decrease after only 8 weeks. And then, same study showing that it works, the MCO, on the different, I would say, TNF and interleukin-6. I mentioned the free light chain from kappa lambda or TNF, different. So there is a decrease, meaning that increasing the convective volume or increasing the convective dose, you can affect inflammatory marker, but see what's happened with the albumin. So they are losing almost 1-2 grams, which is significant after only 8 weeks. And this is the biggest study from the US. So they make this study, again, it's not, I would say, tremendous in terms of time, but large study looking on the primary outcome, free light chain. So clinical performances and some related, I would say, parameters. And again, showing that with the convective action, you can reduce the concentration of the free light chain, beta-2M, same way, complement factor D, and some, I would say, inflammatory markers such as the interleukin and TNF. So it works, it's clear, we can affect some element. Now, if you look on the albumin again, after 24 weeks, it's not significant, but still you see a decrease of the albumin, okay? Then keep in mind. Now, if we compare to the hemodiafetation, and I already showed this slide, if you look on this systematic review of almost 50 studies exploring the beta-2M clearances with the hemodiafetation versus the high flux, you see that the clearance, the average clearances for beta-2M in vivo, so which is body clearances, is almost 90 ml per minute. 90 ml a minute means that within a dialysis session, hemodiafetation, you remove almost 150 milligrams per session. It's not sufficient to correct this the beta-2M concentration, but still, if you multiply the 3 sessions, it's almost 450 or 500 milligrams that you are removing per week. We need to remove at least 800 to make sure that we can control the beta-2M. Now, to do that, you can expand the time, and moving from 4 hours high flux hemodialysis to 8 hours, you see that you can increase the beta-2M mass removal by almost 50 milligrams. And 4 hours hemodiafetation is equivalent to 8 hours hemodialysis for the beta-2M mass removal. Okay, so just remember that the convective action works perfectly. Now, this is a study and a concept which was developed by Manuel in Catalonia, the global removal score. Why is interesting? I think it's not applicable in a clinical setting because you need to collect, I would say, different markers from urea, beta-2M, myoglobulin, and so on, which is quite costly. But at the end, you can cover a spectrum from 60 to almost 45 Dalton. And if you make this calculation corrected by the albumin loss, then you get this type of coefficient which is presented. I just selected two filters. One is a Terra Nova, and the other one is a Cordiax used in terms of hemodiafiltration. And again, you see that hemodiafiltration do better than the Cordiax, than the Terra Nova. So that means by the online hemodiafiltration, we are a little bit more, I would say, superior. Now, from the albumin, and the same story, you see that the albumin in that type of setting, which was developed by Madwell, the albumin loss is almost the same. So, again, for the different aspects, the free light chain now, if you compare for the Madwell study, the free light chain, if you consider that it's a toxin substances, is better to do with hemodiafiltration as compared to the MCO filter. And again, this is coming from the US. Recent study from the CMS showing that when you plot all this study who explore the albumin loss, you see that in average, albumin loss per MCO session is close to 2 grams per session as a minimum, showing that it's a good effect. So in terms of clinical performances, I will close this chapter for the Terra Nova. 8 trials, I would say limited numbers of patients, removal rates for different substances, including, I would say, free light chain, beta-2M, and different elements. And at the end, if you just make a summary, it's a comparable, I would say, instantaneous clearances for all these substances, including, I would say, the larger ones from the MCO to the hemodiafiltration. So today, in terms of clinical performances, there is no significant differences. So now the point is to move from clinical performances to patient outcome, which is a different story. As you know, doing some of the treatment, you need to reply this and multiply over the time to make sure that you can remove the sufficient amount of solute. So patient outcome in terms of mortality, quality of life, hospitalization is something which is called hard clinical endpoint. And this is what we are looking for the patient. It's not just the clinical performances. And this is, of course, the way to make dialysis adequacy. You want to correct all these parameters. It's not just removing, I would say, some selected solute. And now, if we look on all-cause mortality with Terra Nova, again, from this systematic analysis, no significant benefit. So if you look on the different study, it's almost on the line 1, so there is no clinical evidence to show that Terra Nova do better for all-cause mortality. And the same story for all cause of hospitalization. So this meta-analysis does not show any, I would say, beneficial effect for the hospitalization. So again, looking on the outcome-based study, brief summary, I just put all the studies are very short-term, less than 1 year. No safety issue, no significant reduction of mortality, no significant reduction of morbidity. So at the end, there is no proof of superiority. Now I'm switching on the hemodiafiltration. And of course, as you know, there are already 4 randomized studies reported in Europe. Only one get a positive primary outcome from Spain, with a reduction of mortality by 30% after 3 years. But all the study, the other one, show a trend which is not significant on the statistical point of view. Now, this is why in this consortium, we went back to this 4 randomized study and create a pooling project where we went back to the data set of the patient and completed the data set. So we went to follow the patient till the end of follow-up and make a new reanalysis. This is called individual participating data analysis. And if you see this study, which is, I would say, created from a new population set, you see that the mortality is reduced by 14% for the all-cause and 23% for cardiovascular mortality. So again, 3 years follow-up, a significant reduction of mortality. But what is the driving force? It's not a magic name of the hemodiafetation. The triggering effect is linked to the convective dose. And this is why I put this slide showing that if you move from the left, convective volume, which is lowest than 20 liters, to the maximum, 26, 30 liters, and you look at that ratio of mortality on the top, you see that there is a decrease. And the reduction of the mortality is definitively linked to this convective volume. So less than 23 liters, which is the yellow area, you don't get any beneficial effect. You need to move on this right side to get the beneficial effect. And this is put or confirmed by different, I would say, national registry. I put the 3 main registry from France, from Japan, from Australia, New Zealand, large data set of patients, unselected population, because this is a national registry showing that in all cases, hemodiafetation reduced mortality by 20 to up to 37%, depending on the country. So the last study, who make a head-to-head comparison between hemodiafetation and the expanded hemodialysis, is coming from Korea, South Korea. This is the design of the study, so it's almost randomized study for 1 year in 86 hemodialysis patients with a primary, I would say, outcome based on the cardiovascular biomarkers and the secondary outcome based on the mortality and vascular calcification I will show you. And this is a summary. So if you look cardiac function and cardiac morphology, from the pulse wave velocity, left ventricular ejection fraction, left ventricular mass, there is a beneficial effect for the both expanded hemodialysis and hemodiafetation, confirming that a convective action is beneficial for the heart. The only difference is coming from the calcification artery coronary score, which shows that the trend is increasing, significantly increasing with the MCO and very stable with the hemodiafetation. So this is the only study head-to-head showing that there is a beneficial effect on the cardiac functionality and morphology, except for the calcification, which is worsening by the MCO. In terms of mortality, no significant effect. Of course, 1 year is quite limited, but there was no significant differences. So the last point is the treatment paradigm shift. And you know that life for renal replacement therapy starts almost 60 years. It's not finished. This is 40 years for your society, but it starts in the US and different places in the world. And every 5-10 years, there is a new shift. So to make a shift in a treatment, you need to get almost more than 50 or 55% of your patient treated by a certain modality. So what will be? I don't want to go into detail from the low flux to the high flux, from the acetate to the bicarbonate. We do have different examples of paradigm shift. So what will be the next shift? The next shift is just summarized on this diazer markets. If you see on the slide, within the next few years, so 2018 versus 2025, the market will increase almost. Today, 66% of the high flux will move to 80% of the high flux. So this is already engaged. So the high flux is already a new paradigm shift, and the low flux almost disappearing or vanishing over the time. So the next question is to know what will happen with the convective therapy. This is the prevalent use of hemodiafetation worldwide, and this morning I heard about a PD. For the hemodiafetation today, 2022, we are already close to more than 450,000 patients treated worldwide. So that means twice as compared to the PD patient. And still the trend is growing. It's growing by 11% per year. So the point, different places, I don't want to go into details. This is, of course, from Europe on the left side and Asia-Pacific region on the other side. You see in Europe it's almost 25%. Japan is 35%, but still growing. So the point is where do we stand and where do we want to go? And this is marketing, and this is a way to move in a renal replacement therapy. So the marketing approval for use and clearance of different technique or device, then you put that in a large clinical trial, then evidence-based medicine, and then you move to treatment paradigm shift. I just put, I would say, two parts, HDX versus HDF. HDX is at the starting point. HDF is almost at the next point, and we expect to get a new paradigm shift in this element. Just summary, what I said about expanded hemodialysis versus hemodiafetation. I don't want to go into detail and control, I would say, TMP, convective dose, which is not perfectly controlled except depending on the blood flow and resistance. We get a lot of clinical performances, which are fine, but we are missing a lot of outcome-based study as compared to the hemodiafetation. So just to keep you awake, we are far from comparing two elements. We are comparing, I would say, orange versus mandarin, if you want. So just make sure you keep in mind, so HDX is not HDF today, so it's a step ahead, but in between, I would say, high flux and the next hemodiafetation. Thank you very much for your kind attention.